Right. Hi, everyone. Thank you for joining us this evening. Tonight's webinar will be given by Dr. Jeff Rihn. Dr. Rihn is one of our spine surgeons here at Rothman Orthopaedics, and he sees patients in our Media and Malvern office locations. If you have questions throughout the presentation, please feel free to enter them at the bottom of your screen. There's a Q&A box. Dr. Rihn will take time at the end to answer as many as he can. He may not get to all of your questions, but I know he'll try his best to answer as many as possible. So thanks again for joining, and Dr. Rihn, you can take it from here.
Hi, thank you. Welcome, everyone. Thanks for logging on this afternoon. Hopefully, you all take away something from this webinar. And again, like like she said, please remember to submit some questions because at the end I'll try to answer as many as I can. Okay. So this webinar is going to focus on low back pain, and it's a very common problem. And I'm going to start by just going over some of the potential causes for low back pain, and then move on to discussing some treatments and then some ways, hopefully you can prevent low back pain. So I'll start with some anatomy of the spine. This is a picture that demonstrates the vertebrae or the bones of the spine. This shows your cervical vertebrae, which is your neck, your thoracic vertebrae, and then your lumbar vertebrae. And the conditions I'm going to talk about today focus mostly on the lumbar vertebrae, the low back. So these are highlighted in blue. You have 5 lumbar vertebrae, and then you have a sacrum down at the bottom. This picture on the right is what a lumbar vertebrae looks like. So this is the bony part of your spine. It has a vertebral body in the front, and it has the lamina in the back, and then this is the spinous process. That's the tip that you can feel underneath your skin in the back. But it's more than just bones. There's a lot of structures in the spine, and it's they have complicated relationships. So in between the vertebrae, which I'm outlining here, are the discs, and the discs are mostly water, and they serve as shock absorbers between the vertebrae. And in the back of the spine, there's ligaments that connect the vertebrae together. There's muscles throughout the back of the spine and the front of the spine, and they attach to the bones through tendons. And then in the back of the spine, there's also facet joints, and they are joints that provide the spine stability. And all of these areas can lead to problems that can cause back pain. This is just a side view of the spine. So again, there's a vertebrae in the front, the disc in between the vertebrae. These are the facet joints in the back. Low back pain is very common. 80% of the adult population at some point in their lives has low back pain. So I imagine that a lot of the people on this webinar have had back pain at some point in their life. If you take a survey at any point in time, up to 40% of adults have back pain in that moment of time. And up to 13% of adults develop chronic back pain. That means that it's not just a back pain flare-up that kind of goes away. It's back pain that just persists and it becomes a chronic problem. Treatment for low back pain represents the most expensive medical problem that we deal with in our country. And it's regarded as the leading cause of disability, nearly twice the burden of any other health condition. So there's some well-known risk factors for developing low back pain. And I'll just go through a list here. And this is most of them, but there's some others. First of all, is strenuous physical work. So if you do a job that requires a lot of lifting and bending over years and years, that puts you at risk for having low back problems. There is an underlying genetic component, meaning your genetic makeup can lead to degenerative disc disease, which can cause low back pain. So we do see conditions that cause low back pain that tend to run in families. Obesity has been associated with low back pain. Smoking, stress has been associated with back pain. Sedentary lifestyle or low physical fitness. So if you're fairly sedentary and you don't exercise a lot and your core muscles get weak, that can put you at risk for developing low back pain. Interestingly, the incidence of low back pain declines with aging to some extent. So low back pain tends to affect people in 20s, 30s, 40s, 50s. As you get older, the low back pain somewhat can subside, but the problem is that's when nerves start to get pinched and it can cause pain going down the legs. So I'm just going to run through some of the common causes of low back pain. This is a muscle and a tendon that attaches to your spine. So probably the most common cause of back pain is a muscle strain. And you can have a muscle strain from bending or lifting or twisting. Um, Another cause of low back pain is discogenic pain. That means back pain that comes from the actual disc in between your two vertebrae. So in this picture, on the right, on the left side, this is a healthy disc in between these two vertebrae. And on the right side is a disc that's gone through degeneration. So as you age and as the disc degenerates, it collapses. You get increased blood vessels and nerves growing into the disc, and you lose the water and the hydration of the disc. And then the vertebrae actually on either side of the disc starts to change. You can see it becomes irregular. And this is a process that can be associated with a lot of pain. The facet joints that I mentioned earlier are the joints in the back of the spine. They also can develop degenerative disease, just like your knuckles or your hips or your knees can develop arthritis. These little joints in the back of your spine called the facet joints can also get arthritis. So up here you can see a normal facet joint. It has like fluid in it, it has cartilage on it, and it's bound by a capsule. But over time with degeneration, you can lose that cartilage. If any of you ever heard of bone-on-bone arthritis in like your knee or hip, you can get the same thing in these facet joints, which you can imagine can be painful. This is an MRI image. I don't know if any of you ever looked at an MRI, but this is an MRI of the lumbar spine. And this process that everyone's spine goes through with aging is called spondylosis. Spondylosis refers to the age-related degeneration of the disc in the front of the spine, the vertebral body end plates next to the disc, and then the facet joints in the back. So that process is referred to as spondylosis. And again, everybody to some extent as you age goes through this process. And you can see on the left side, this is a fairly normal spine with vertebrae, discs in between, nice, healthy, wide open spinal canal, which is this white tunnel. And you can see how dramatically different this spine looks. So in this spine, which we would call a spondylotic spine, the end plates of the vertebrae are irregular. There's not much disc left between the vertebrae. The discs are bulging out of the back towards that spinal canal. And this, again, this process occurs with aging, and it also has some association with genetics, activity throughout your lifetime, any traumas that you may have suffered in smoking. This is an X-ray of a spine, and another common cause of low back pain that I see is scoliosis. So when you think of scoliosis, a lot of you maybe think of children who have scoliosis that they used to pick up in gym class that they brace, but adults also get scoliosis. And it occurs because as these discs collapse and degenerate, they do so asymmetrically, and they collapse more on one side than the other. And as a result, the spine can curve. And you can see in this X-ray, the spine is curving, and you can see these little bone spurs that are forming. These little pointy bone spurs are forming as a result of the degeneration. And this is a more dramatic example of a degenerative scoliosis in an adult. So the curvatures can become pretty significant and painful. Fractures is another common cause of back pain. And one that most of you may be familiar with or have heard about is a compression fracture. Compression fractures are age-related fractures that are largely due to osteoporosis. But there's other types of fractures. This picture up on the right is a traumatic fracture. So this person was in a car accident, and you can see what happened to this vertebrae. So this is a normal vertebrae, but this vertebrae is broken into multiple pieces. And then a third type of fracture that you may or may not be familiar with is a stress fracture. You can get stress fractures in all different parts of your body, but the spine is not excluded. This is an L5 stress fracture, and this type of fracture is actually present in up to 7% of the population, and it tends to start in adolescence. So kids who are doing all the sports, and it's associated with overuse with repetitive sports and injury. They can develop these little cracks in their vertebrae, which most of the time heal on their own and don't need to have any surgery. So this is another cause of back pain that I commonly see in my office. This is a disc herniation. So this disc in between the vertebrae, which is this, can herniate out into the spinal canal. So you can see this large gray thing and traveling into the spinal canal, which is where all the nerves travel. And you can imagine that could be very painful, and it can be associated with other symptoms such as leg pain, numbness, or weakness in the legs. And can cause what many people would refer to as sciatica. This is lumbar stenosis. Lumbar stenosis just means that the spinal canal is becoming narrow. So in this MRI image, again, this white tunnel is the spinal canal, but you can see right here, there's narrowing, and that's referred to as stenosis or narrowing. And you can see in this patient, it's not necessarily because the disc is that herniated, because it really isn't herniated. You can see that there's this stuff in the back that's kind of growing into the spinal canal. And that stuff is called ligamentum flavum. And it comes off of the facet joints that have arthritis, and it can build up and narrow the spinal canal. And this can be associated with, cause a lot of back pain, but this also can cause leg symptoms, heaviness or weakness in the legs, numbness and tingling in the legs. Um, this is this typically gets worse when you stand and walk. When you stand upright and walk, the symptoms build and build and build, and then you have to sit down for relief. And you may see patients, or yourself may, when you go grocery shopping, have to grab onto the cart. It lets you lean forward a little bit, and it opens up the spinal canal a little bit, and then you can walk further. So we actually use the grocery cart sign as an indicator that someone might have stenosis. When you ask them about this, they say, "Yeah, I grab onto the grocery cart and lean forward, and it helps my symptoms, and I can walk further." So that's a telltale sign that they may have stenosis. This is In this image, this depicts lumbar spondylolisthesis. So I'm throwing all these terms out here, but lumbar spondylolisthesis occurs when one vertebrae slips on another one. It means that one of the lumbar vertebrae is unstable for a variety of reasons, and it shifts on the other one. And this can be associated with nerve compression. Um, as this shifts forward, these nerves that travel through the canal can get kinked. This is an MRI of someone with spondylolisthesis. You can see that this vertebrae is shifted forward on this one. That's L5 and S1. And the nerves, the disc is bulging, and this would cause a significant nerve compression. So in addition to back pain, can also cause the leg pain, the weakness in the legs that you get because the nerves start to get pinched. So these are some less common causes for back pain, but certainly potentially severe causes. Infection. You can see in this MRI image, this is a normal disc, but up here you can see this disc looks completely destroyed. It's full of white fluid. And this is an infection in the spine. And I actually get consulted in the hospital fairly frequently to see patients who have this. Um, This infection can get into the disc space and essentially destroy the vertebrae on either end of it. And this is often something that requires surgery. So you can imagine how painful that could be. Another cause of back pain is tumors. So either primary tumors, meaning tumors that start in the bones of the spine. Now those are very rare, but more commonly a metastatic tumor, meaning you have cancer in some area of your body, whether it be your colon, or your lung, or your prostate, and it can spread. In one of the areas it spreads, actually the most common area it spreads is the spine. And you can see that these vertebrae are white. This one actually broke because there's tumor filling it. And as the tumor fills it, it gets weak. So this person has two vertebrae that have metastatic cancer inside of them. And then there's other non-spine related causes for back pain that I'm always trying to think about and be aware of when I see somebody with back pain. Um, There's a lot of structures in the right around the low back, including your kidneys, your bowel. There's arteries and veins, and issues with these other structures can present as back pain. I don't know if anyone's ever had a kidney stone, but kidney stones can be very painful, and it's not uncommon that I see some in my office that it ends up being a kidney stone. Aortic aneurysm, it's an enlargement of your aorta. If it starts to leak, it can cause severe back pain. That can be an emergency. There's gastrointestinal issues, constipation, gallbladder stones, and there's genitourinary issues and pelvic issues, like endometriosis, ovarian issues can cause back pain, and pancreatic cancer can cause severe back pain. So these, it's just something to be aware of, and something whoever's seeing you for your back pain should be aware of, that if there's not a readily identified cause of the back pain, then these are some other things you have to consider. So I'm going to talk about treatment now and just go through kind of that same list and review how we treat each of these problems. Muscle and tendon sprain, again, is probably the most common cause of back pain. And this is usually an acute issue that you get from bending or lifting or twisting or doing sports or golfing. And you get acute low back pain. It doesn't tend to radiate down your legs or cause any nerve symptoms. But this generally is just treated with a little bit of rest, not prolonged bed rest, because it's been shown to be adverse to lay in bed for too long. So you do want to get up and move as tolerated. Take anti-inflammatory medications such as Advil or Motrin. You can apply ice to the area, typically after activity, or moist heat to the area, and that's typically applied before you try to do activity. If the pain's severe, sometimes I'll call in a steroid. If you've ever heard of oral steroids, they can be a strong anti-inflammatory medication. They're usually very effective. And then once the symptoms start to improve, I'll oftentimes recommend some physical therapy just to get the muscles strong and hopefully prevent these issues in the future. If you think someone has a tendon sprain or a muscle sprain and has back pain, but it's not getting better, because these things tend to get better in 1 to 2 weeks to some extent, and then resolve within 4 to 6 weeks. If it's the pain's lingering and not going away, that's when you want to do more of a workup, maybe get X-rays and MRI, some lab work, and try to figure out exactly what's going on. Because if it's a sprain or a strain, it should be getting better. Now, this is that X-ray I showed earlier, and this is somebody with severe spondylosis of their spine and back pain. And this is a very challenging problem to treat. There's a lot of treatments that we try to get this type of back pain under control, and some of them help, and sometimes it doesn't help. And it can be a very challenging and frustrating problem for the patient, but also for the treating doctor who's trying to help. So some things we try, just activity modification, trying to avoid the things that tend to flare it up. Physical therapy can be helpful, chiropractic treatment, local modalities such as like ice, moist heat. You can get local massages in the muscles around the spine. Medical management, including the anti-inflammatory medication, muscle relaxers, intermittent steroids for acute flare-ups, and then injections. I'm sure many of you have heard of spinal injections. There's a lot of there's a lot of different types of injections. An injection usually involves a steroid. That's usually what they inject into the spine. And you can inject steroids into the spinal canal. That's called an epidural injection. You can inject them into the facet joints. That's called a facet injection. And then sometimes in the office, the doctor will just put a little needle into the muscle or where it tends to be most tender, and that's called a trigger point injection. But these all involve steroids. There's radiofrequency ablation, which I'll talk about in a minute. And it is important to mention that for degenerative disc disease and back pain, when it's this extensive, in the absence of nerve compression or stenosis or disc herniation, it's rare that we do surgery for this problem. Surgery for low back pain in the absence of nerve compression has not been shown to be terribly effective. So we try to avoid that if we can. I'm just going to go through a couple of treatments that I get asked about a lot, and that are, some of them are some newer literature about them and are somewhat experimental. But things that I get asked about a lot are radio frequency ablation, platelet-rich plasma or PRP, and therapy, stem cells. I was in the office today and I got asked about these last two about 3 or 4 times. So it's on patients' minds. So I thought I would just touch on a little bit about what that is. So this first treatment is called radio frequency ablation. Um, in this radio frequency ablation, the pain management doctors put a probe down by the little teeny nerve roots around the facet joints, and they essentially burn them. They use radio waves to heat up the tip of the probe, and essentially burns the little teeny nerve roots around the facet joints. You can see this image here. Um, they're also more recently started doing something called basovertebral nerve ablation, where they actually put the probe into the vertebrae itself and ablate or burn this nerve that is felt to sense pain in the actual vertebrae. And that's a neuro procedure called intercept. And our pain management doctors do this. This is just a study. I don't want to get too into the studies behind this, but this is just a prospective randomized study, which means it's a pretty well-designed study that looked at that intercept procedure and said that patients actually did pretty well with it compared to normal physical therapy and non-surgical treatment for back pain. So the next intervention I want to talk about is platelet-rich plasma. Some of you may have heard about that or even had it, but platelet-rich plasma, to perform this, the provider aspirates blood out of a vein in your arm, puts it in a test tube, spins it down in a machine, and as you spin blood down, it separates out into these different layers. And they get this one layer that is called platelet-rich plasma. It's basically plasma or the fluid part of your blood that has a lot of platelets in it. And we don't really understand why it works. The mechanism isn't fully understood, but it's felt to be related to growth factors that this platelet-rich plasma has in it that stimulates cells that help healing and help with inflammation. So they do platelet-rich plasma injections for all kinds of tendon injuries, and they've started doing it in the spine. The problem is there's not many studies on it, and this particular study was a systematic review, meaning these authors looked at all the papers that were published on platelet-rich plasma for degenerative disc disease, and they found that there's really a low level of evidence, and there may be some positive results, but better studies are needed, essentially, is what they concluded. And then this treatment I want to talk about is stem cell therapy. I'm sure all of you may have heard of stem cells. Stem cells are essentially cells that can develop into all different kinds of tissue. They have a lot of potential to divide, and depending on what environment you put them in, they can develop into different tissues, including cartilage, which is what we're interested in. This is a very busy slide, but just quickly on the left, stem cells can be injected into the disc that's degenerating. All these factors get released. And the hope is that by injecting these stem cells, that there's a decrease in inflammation and cellular death, and an increase in cellular proliferation, and to some extent, the hope is that it can restore the natural disc. Now, this is very experimental. It's been done in animal. There's a lot of animal studies that support it, both small and large animal studies, and there's a few clinical studies in humans. This is one study, again, a prospective high-level study where they injected these stem cells into patients who had degenerative disc disease, and they compared it to a sham injection, meaning some patients got stem cells, some patients just got like fluid, like saline. That's called the sham or the placebo. And this study found there is no difference. At 12 months, no difference in back pain, no difference in what the MRI looked like. So this study would suggest that stem cells aren't really effective. This is a more recent study looking at stem cells. And this study shows some promise. It shows that there was some improvement maintained at 2 years after the injection. I just do want to note that there are no stem cell therapies that are FDA approved for use in the spine currently, and that all such treatments are considered experimental. The next condition is a compression fracture. So these I commonly see compression fractures in patients in the hospital who have fallen. The typical treatment for a compression fracture is a brace and early mobilization and eventually physical therapy. Most compression fractures will heal on their own without any intervention. It just takes time. In the first couple weeks can be hard. It can be painful. It can be hard to mobilize. But if you get past the first few weeks, typically it heals and the patients do well. If it's not getting better and the patients have trouble mobilizing, that's when we may want to consider doing kyphoplasty or vertebroplasty. And you may have heard of this where they put cement in the vertebrae. So this is just an image that demonstrates how kyphoplasty is performed. A probe is put into the vertebrae that's broken. You can see this vertebrae is broken, it's wedged down. A balloon is blown up to kind of help reduce that vertebrae into a more normal shape. And then cement is injected into that void to give it stability. So this is a pretty common procedure. Vertebroplasty is the same thing, but it's just without the balloon. So they just put cement in. Both have been shown to be pretty successful in patients who have trouble mobilizing with a compression fracture. So those are most of the non-surgical treatments that we use for back pain. In the next part of the webinar, I'm going to talk about patients that need actual surgery and have back pain. So surely for traumas, that bad trauma I showed, or tumors or cancer or infection, those patients all need surgery typically. But those are pretty rare problems. But I'm going to focus mostly on degenerative issues, which is the vast majority of patients that I see, and by far the most common reasons we do spine surgery. So that first picture I showed you of the disc herniation, this huge herniation here where the disc is herniated into the spinal canal, causing leg pain or sciatica. A lot of these patients will get better without surgery, with physical therapy, with time, with injections, with anti-inflammatory medication. But in some cases, they don't get better. And this is a condition that responds very well to surgery. And the surgery to treat a disc herniation is called a microdiscectomy. So this is just a little depiction of what happens during surgery. This is the skin. A little incision is made, and the disc herniation is pulled out off the nerve. It takes about a half an hour. You typically go home the same day. And this surgery is very effective in treating lumbar disc herniation. This is that picture that I showed you of stenosis. So this is a different picture, but this patient too has stenosis. So stenosis is different than a disc herniation. Stenosis is a buildup of that arthritis closing in on the spinal canal. It tends to affect older patients, but this too, if it doesn't respond to therapy and injections, which we usually typically try first, responds pretty well to surgery. And the surgery that you do for stenosis is called a laminectomy. And this is a picture of what a laminectomy involves. An incision is made in the back of the spine, and the bone on the back of the spinal canal is removed. It's called the lamina. So the point on your back you can feel, or the spinous process, and the lamina is removed, and that opens up that tunnel where all those nerves are being compressed. These patients can tend to stay maybe a day or two, but it's usually a pretty quick recovery. You get out of bed the same day. These patients tend to be older who need laminectomies, so they may have other medical conditions that have to be taken into account when trying to get the patients home. This is the spondylolisthesis diagnosis, where the one vertebrae is slipped on the other. So you can see not only does this patient have stenosis, the patient also has vertebrae that are slipped on one another. So this patient, if they don't respond to non-surgical treatment such as physical therapy and injections and medication, this patient would need not only a laminectomy, but also a fusion. And you add the fusion in to stabilize those vertebrae that are slipped on one another. So fusion's a little bit more invasive, a little bit longer of a surgery, takes a couple hours. You stay in the hospital for a few days. But again, if you do these procedures for the right reasons and the right patients, where they MRI shows stenosis and instability, the patients typically do very well. This is scoliosis. I mentioned adult or degenerative scoliosis. This is a full-length X-ray of a woman with scoliosis, and you can see how curved her spine is. And this is the pelvis, And this is her torso. So her pelvis is shifted off to the one side. This can be associated with severe back problems, balance problems, trouble standing and walking, and it tends to progress over time. This is a, sorry, this, the typing didn't come up well, but this is this is just me making measurements of the different ways we measure the curves in preparation to do surgery. And this is a picture of the, representation of what the woman would look like with a condition like this. It can be pretty disfiguring, and the posture can become way off. That's a close-up of the lumbar spine. You can see this should be straight on this view, but you can see how curved it is. And this is what we do with surgery. So this is the preoperative X-ray. And then through fusion and instrumentation, you can see these are the screws that are put in, and then they're connected by rods, and the spine is straightened out, and her body is more centered over the pelvis. And patients, even though this is a big surgery with a longer recovery, these patients usually end up very happy. Recovery from these different procedures is variable. Um, the disc herniation patients get better quicker. Obviously, the scoliosis patients with the bigger surgery takes a little longer. All the patients are seen at 2 weeks after surgery. They have their sutures removed, get x-rays. For the first 2 weeks, patients are allowed to ambulate and do stairs, but there are some lifting and bending restrictions. From 2 weeks to 2 months, still some lifting restrictions, but it's okay to start to drive after 2 weeks, and do some non-impact aerobic exercise and return to sedentary work. And then after 3 months, after the 3-month appointment for most procedures, that's when physical therapy starts and you can start to return to sports and full and heavy work. So I'm just going to touch on prevention. Um, it's important in trying to prevent low back pain that you keep your core muscles strong, maintain your flexibility, and just watch as much as you can how much you lift and bend. I would say one of the most common reasons I see patients for acute low back pain, it relates to lifting and bending. So they picked something up and didn't know it was going to be as heavy as it was, and they pulled their low back, or they were shoveling snow. That's a very common one, or mulching this time of the year, mulching the garden. Anything where you're shoveling or lifting and bending, that's probably the highest risk activity that I see. Um, it's important to stay physically fit as much as possible, to do weight-bearing exercise to keep your core strong and maintain flexibility. Don't smoke, because smoking has been clearly shown to be associated with degenerative disc disease and low back pain. You want to minimize stress. That's easier said than done, but try to minimize your stress as much as possible. That stress can tighten up your muscles and lead to both neck and back pain. Maintain a healthy weight. Obesity has been linked directly to degenerative disc disease and low back pain. And seek treatment from a professional. So if you're having these issues, um, most people, myself probably included, just tend to try to push through it. It'll get better. It'll calm down. But if you hurt your back and it's bothering you, it's best just to get in to see a professional so you can be evaluated, get good advice. And most of the times, I would say 95% of the time, these conditions are self-limiting, meaning they'll get better on their own with either on their own or maybe with some physical therapy and medication. But you don't want to miss some of those other bad things that I showed. So a professional can kind of help you work through that. Prevention osteoporosis. I personally don't treat osteoporosis, but it's a big issue that I see a lot in the hospital because I see a lot of fractures from it. It's most commonly a problem in women. When women reach menopause, it speeds up the loss of the bone density because the levels of estrogen go down. And women can lose up to 20% of their bone density in the first 5 years after menopause. So in this slide, this is healthy bone, and this is what happens in bone that has osteoporosis in the vertebrae. You can see it's just hollow and more prone to fracture. And this happens in your wrist, it happens in your hip. So osteoporosis makes you prone to different fractures of different parts of your body. 1 in 2 menopausal women will have osteoporosis, and most of those women will suffer a fracture at some point in their lifetime. So it's a big public health issue. Again, I don't treat osteoporosis, but it's important to discuss this with your primary care physician. They'll likely recommend calcium, vitamin D, weight-bearing exercise, strength training. Smoking's been associated with osteoporosis, so don't smoke. And alcohol has been associated too, so limit your alcohol. If you have osteoporosis and your primary care doctor finds that, there's medicines you can take to help rebuild the bone too. So it's just important to have that discussion with your primary care doctor. So thank you for your attention. I hope that was helpful to all of you. And at this point in time, I'll take some questions. Okay, so I'll just start with the questions. I'll read them out loud and then try to answer them. So the first one says, I'm quite uncomfortable driving and also as a passenger. Is there any tip to increase support and decrease discomfort? So that's a great question. Sitting actually increases the pressure in your disc. So patients with disc problems tend to have trouble sitting for long periods of time. And certainly that includes driving. And a lot of the seats in the cars aren't great. So some of them have built-in lumbar supports, and my car does, but I found that it's not very effective. So this actually happens to me too. If I take a long ride, my back starts to hurt. I have to start shifting around to try to get comfortable. And so what I did and what I recommend is getting a lumbar support pillow. And they sell different shapes and different sizes, but that's what I found to be the most effective um, intervention trying to manage that back pain you get when you drive. Um, if you haven't been evaluated, certainly it wouldn't hurt to get looked at to see why maybe you're having that much pain in your back when you drive. Um, sorry. So hopefully that answer helps. What is your next question is, what is my opinion on using hyaluronic acid for back pain? So for those of you who don't know, hyaluronic acid is a lubricant that was first used in patients with knee arthritis. So you may have heard of Synvisc. There's a lot of them on the market now, but basically they inject it into the joint, and sometimes they'll do one, or sometimes they'll do a series of three or five, but it's meant to lubricate the joint and help with the symptoms of arthritis. We don't typically use it in the back. Um, it's not intended to be put in a disc in the disc space. Theoretically, you could put it in the facet joints because they are similar type joints to your knee and your hip. But it's not something that's done in the spine. Okay. Let's see. Does drinking water help with how the disc area becomes dehydrated? That's a good question. The disc is mostly water. It's 95% water. And as you age and as that disc degenerates, it loses its water content largely because the proteins in the disc that hold the water start to break down. So I don't necessarily think drinking more water will keep them hydrated. It's not a problem with not having enough water. The problem is actually the proteins in the disc itself are broken down. So generally speaking, it's great to stay hydrated and drink a lot of water for your general health, but doing so won't necessarily cause that disc to become rehydrated again, because the problem is the actual proteins in the disc don't hold on to the water anymore. Um, what is the treatment for spinal stenosis with upper leg to thigh and knee nerve pain? Okay, so this is a question about spinal stenosis. That's when your spinal canal in your low back becomes very narrow and starts to pinch the nerves. And the typical symptoms of someone with stenosis is low back pain, but also as they stand and walk for long periods of time, their legs start to either hurt or turn numb or tingly, or even maybe feel heavy or weak. So say someone with spinal stenosis can walk about a block, then they feel like they have to sit down because their legs feel really tired or start to hurt. So the initial treatments for that we usually use are physical therapy, and there's a set of therapy exercises called the Williams Flexion-Based Exercise Program, which is intended to help patients with lumbar stenosis. And it's a exercise program that's based on exercises that are done in a neutral or a flex position with your flexion at the waist. Patients with stenosis don't do good with extension, like back bends. So if you have stenosis, you shouldn't be doing any extension exercises. Um, and then the treatment progresses from there to include maybe a series of epidural injections. And then if that's not effective, then that's when you would potentially go for surgery and get a laminectomy. Um, is an epidural injection the same as a steroid injection? So an epidural injection is typically a steroid where the steroid is put in and around the nerve roots. So there's other types of, like a facet injection too, it would be a steroid. But yes, an epidural injection is typically some version of a steroid. So if fusion is performed once for stenosis and spondylolisthesis, is it common to need it again in another spot? So that's a really good question. Um, I showed you all the vertebrae in the spine. You have 5 lumbar vertebrae and 12 thoracic vertebrae and a sacrum, and there's discs in between all those vertebrae. So once you fuse 2 of those vertebrae together, or 3 of them together, how many you fuse, there's always a level above and below that will take on more stress and over time can degenerate and cause more problems. So what you run into on occasion is if you once you fix 2 vertebrae together, you start developing a problem at the next level, which over time can build up and cause nerve compression at that level. So that's when you hear about patients needing to get multiple spine surgeries. Typically it's because you fix one issue and then the rest of your spine's still working and bearing load, and every time you bend and lift, it's still working, and it can wear out at other levels. So that does happen. Um, Sleeping positions. I get asked a lot about mattresses and sleeping positions. I think it's a very individual thing. Everyone's a little bit different in how they feel comfortable sleeping. I would say that people with stenosis don't do well straight. That's why they can't stand up straight. So it would be beneficial for them more to sleep in a fetal position or a curved position on their side. And in terms of mattresses, the recommendation is a medium firm mattress. Um, to support the spine. You don't want it to be too soft or too firm. And it's also is nice to, they're expensive, but the adjustable mattresses that you can adjust and that you can raise and lower are ideal. But they're very expensive. So what kind of exercises keep the back in shape? So I showed you that slide with all the muscles on it. So there's a ton of muscles in your back and your stomach, around your spine. And the general set of exercises to maintain support for your spine are called core exercises. Um, there's a huge list of core exercises that you can do. I'm not a physical therapist, but if you are interested in that, it would benefit you to meet with a physical therapist that can not only explain to you what those exercises are, but also show you how to do them the right way. Um, But those are considered core muscle strengthening exercises, and there's a lot of versions of them. But I would recommend seeing a physical therapist for that. So, is there any specific treatment for low back arthritis? I have no pain when sitting or laying, but it hurts when standing and walking. It sounds like that was probably stenosis. If your pain is mostly with standing and walking, the facet joints get loaded when you stand up straight and walk. And if there's any narrowing in there, it would be relieved when you sit or lean forward. So in that situation, I would be concerned about that you might have stenosis, which again, I talked about how to treat that. But in general, arthritis, including back arthritis, the mainstays of treatment for arthritis are anti-inflammatory medicines like Motrin or Advil or Aleve, moist heat, stretching, range of motion, and exercise. I get sciatica symptoms when I take my daily 1 mile walk. It came on suddenly and has bothered me for 2 months. Any suggestions on healing? So if you've been fine and then all of a sudden you're getting radiating leg pain down your leg when you walk, that suggests that you probably have stenosis or a pinched nerve. Um, and that would require an evaluation. So that evaluation would be include x-rays and an MRI to see exactly what's going on. And um, and if you want to just try to get through it on your own, you could do you could look up the Williams exercises online. You can take Advil or Aleve. You can use moist heat. Those are things that you could do on your own to try to overcome that. But if it's persisting for 2 months, that's probably something that you should be evaluated for. So I had a consultation with a this is a question. I had a consultation with a neurosurgeon who then referred me a specialist who performs intercept procedures. What is the success rate? So um, the intercept is that procedure that I showed you where they're doing ablation of the basovertebral nerve in the vertebrae. It's a pretty new procedure, and there's very narrow indications, meaning not every patient's a candidate for it. So for that procedure, you would see a pain management specialist or a physiatrist, and we have a number of those in our group. And they would get X-rays and an MRI to see if you're a candidate. It sounds like you may have already done that part of it. But the success rate, I showed this study earlier. There is a very well done study on Intercept that showed that compared to physical therapy and other non-surgical treatments, that they did pretty well with the procedure. So if you are are deemed to be a candidate, and I'm not sure you've had that workup yet, then if you have back pain that's not getting better, it's probably worth something trying, worth trying it. So is stenosis a recurring problem after spinal surgery? So yes, after you have stenosis treated with what's called a laminectomy, if you don't fuse it, it can grow back in the same area. It usually does so very slowly, but it can grow back. And then if you do have a fusion, you can develop stenosis at another area in your spine. And I already kind of explained why that was. So it can come back either in the same area or the area above or below. Is there issues with seeing a chiropractor if diagnosed with scoliosis? I don't think at all there's an issue. I refer a lot of patients to chiropractors. Um, the only the only incidents when I'm cautious about is when there's spinal cord compression, and the chiropractors are cautious too. They don't want to manipulate anyone who has spinal cord compression because it can make that worse. But in the absence of any severe spinal cord compression, then I think chiropractors are great, and they surely can help potentially with scoliosis. Do you lose range of motion with a spinal fusion? Well, by definition, when you fuse two vertebrae together, they don't move again. So at that one level or however many levels you have fused, you won't have any motion. But what we found actually is patients who have fusion tend to have less pain after the surgery is performed and after they recover, and they actually regain their motion. Oftentimes, their motion's better than when they came in with their problem because the spinal problem initially was limiting their motion so much that they couldn't bend and lift and bend and twist. So what we actually find clinically is after a fusion that patients actually can regain motion. And even though you don't bend through those levels that are fused, you can still bend through the other levels. And then you can bend a lot through your hips. So your hips can compensate. How do you know if a pain in the back top of your hip in the back is from hip arthritis or a back issue? That's a very good question because there's a lot of overlap between back pain and hip pain. There's actually a condition called hip back syndrome where you have both. So commonly in my office, I see patients with both, or I see patients um, who think it's their back and it's actually their hip, and vice versa, who think it's their hip and it's actually their back. So to tell the difference, you really need to get like a physical exam and maybe some imaging. But it's something that with a little bit of a workup and a good physical exam by someone who's knowledgeable can help you figure out. Generally speaking, hip arthritis and pain from the hip tends to affect you in the groin more. So if you walk and it goes into your groin, that's an indication it's more likely from your hip. Whereas if it's in the back of your hip up more towards your back or buttock, that may be coming more from the back. But there is overlap, so it's good to get an evaluation. Do I suggest ablation for stenosis? So I talked about ablation. That's where they burn the little nerves around the joints or in the vertebrae. And ablation is a treatment that's done for back pain from degenerative facet joints or degenerative disc, but it's not intended to treat stenosis. So burning those little nerves doesn't do anything to open up the tunnels where the nerves travel. So ablation can be performed if you have a lot of back pain, but to treat symptoms from stenosis, with the leg symptoms getting heavy when you stand and walk, that's usually treated with injections of steroids, physical therapy, and potentially even laminectomy. So how can someone tell if nerve tingling and numbness in the foot is caused by nerve impingement in the lower lumbar or by severe osteoarthritis in the knee? So that's a good question. There's several things that can cause numbness and tingling in your feet. One is a pinched nerve in your back. One is something called neuropathy, which means the little teeny nerves in your actual feet and legs develop problems where you get burning and tingling. Um, and then there's other nerve entrapment symptoms where the nerve can get entrapped at your knee. And I suppose if you had really bad arthritis in your knee, that could affect the nerve that travels right past your knee or your ankle. Um, the way to differentiate that is there's a few things. You can get an MRI of your low back to see if there's a pinched nerve in your back. And really the best thing to do is get what's called an EMG nerve conduction study, where our doctors can help pinpoint what exactly is causing that numbness and tingling. They can differentiate neuropathy. For example, patients with diabetes are prone to neuropathy. They can tell in the EMG nerve test whether you have neuropathy, let's say from diabetes, or if you have numbness in the feet from the back, or numbness from a pinched nerve somewhere along the leg. So that's probably the best study to help differentiate that condition. So I've been seeing a pain management doctor. This is a question. I've been seeing a pain management doctor for cervical epidural steroid injections for 6 years. Now an MRI of the lumbar spine indicates similar issues. I've been afraid to see a spine doctor for fear of surgery since it's their specialty. How true is that? Um, well, so a couple things. Yeah, I'm not surprised that you have issues in your neck and back. So patients who have a lot of disc issues in their back tend to also have a lot of disc issues in their neck. They go hand in hand. Um, so I don't, everybody's afraid of surgery, especially spine surgery. It's very common to get nervous about that. But if you see a reputable doctor who treats these conditions for a living, it doesn't hurt to see them just to get an opinion. It doesn't mean that you have to do surgery, but it's certainly something that might help you understand what's going on and maybe what the different treatment options are. So I would maybe try to get past that fear of at least that initial visit, and just get evaluated to see what number one, what the problem is, and number two, how best to treat it. It's very rare that I see someone and just say, "Oh, you have to absolutely have to have surgery tomorrow. It's an emergency." I mean, that's extremely rare. Most things can be managed conservatively for a while to see if those treatments are effective. On the flip side, there are emergencies that can cause paralysis or irreversible nerve damage, it should be managed in a, urgently. And sometimes I see patients who were afraid to come in, and then they come in 6 months down the road, but they already have a chronic foot drop and permanent issues that at that point surgery won't fix. So if you're having issues you're concerned of, it's best to get them evaluated. It doesn't mean you have to have surgery. It just means that you'll get more information about your condition. So feelings about Coflex. I didn't mention Coflex, but Coflex, and there's other devices, but stenosis is a problem that affects you when you're standing, and it gets better when you're leaning forward. So they've developed little implants that you can put between the spinous process and the spine and essentially recreate leaning forward at that one or two levels. So it's a way to kind of treat mild stenosis. It's not indicated for moderate to severe stenosis, and it's not indicated for patients with spondylolisthesis or instability. There's there's plenty of research on Coflex. In my opinion, I don't do them. I've revised a lot of them because I think some doctors are putting them in patients where the stenosis is so bad, and it's a little bit too much to expect that little device to help. But if you do have mild to moderate stenosis and want to avoid a bigger laminectomy surgery, it's something to consider. There is studies that support it can be effective.
Thanks, Dr. Ryan.
So
I mean, I think we're running out of time,
yeah,
so
so it's almost 5, but I tried to answer as many questions as I could. There's a lot of them. I'm sorry. I wish I could keep going, but I hope you guys got something out of this. And again, if you want to be evaluated either by me, or if you're afraid to see a surgeon, you want to see one of the non-surgical doctors, we have really good non-surgical spine doctors too that can assess your situation and see what's going on.
absolutely. Thank you so much. Yes, if anyone is interested in scheduling a consultation or an appointment, you all have my email address. Please feel free to reach out to me directly, and I'm happy to help get you set up. We did record this webinar this evening, so it will be sent out likely early next week, so that you are able to review it again, and then anyone who wasn't able to log on will be able to watch it as well. Thanks again, Dr. Ryan.
All right,
Great
thanks, guys.
presentation. Thank you so much, everyone. Have a great night.